Good afternoon, and welcome to the Public Health Practice Grand Rounds for February 2010. My name's Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome you to today's Grand Rounds on the topic of the new U.S. Standard Birth Certificate, Opportunities and Challenges. Before we begin today's presentation, I'd like to invite you to visit our website to view our available online and face-to-face trainings. In addition to the trainings available on our website, such as Public Health Nursing and the many archived Grand Rounds, our upcoming trainings include our Core Competency Training Series with Dr. Carolyn Fowler, including the Community Assessment and Formative Evaluation on February 19th. We're also pleased to offer the Problem Solving for Public Health with Dr. Miriam Alexander on March 10th. For those watching online, we invite you to email questions for the presenters at any time during this webcast to MAPHTC, which stands for Mid-Atlantic Public Health Training Center, at jhsph.edu. And if you are watching this webcast in a group, we ask you to take the time to fill out our online sign-in form so that we have a better idea of how many people are watching online. And with that, I'd like to go ahead and introduce our speakers for today. Our first speaker is Dr. Isabel Huron. Dr. Isabel Huron is a director of the Vital Statistics Administration of the Maryland Department of Health and Mental Hygiene and is responsible for the collection and analysis of all Maryland birth, death, fetal death, marriage, and divorce data. Dr. Huron received an undergraduate degree from Penn State University, a master's degree from the University of Pittsburgh Graduate School of Public Health, and a doctoral degree in maternal and child health from the Johns Hopkins University Bloomberg School of Public Health, where she holds an adjunct appointment in the Department of Population and Family Health Sciences. Dr. Huron is currently serving a 2-year term as president of the National Association for Public Health Statistics and Information Systems, which provides leadership and advocacy on behalf of all state and records offices. Our second speaker is Dr. Bernard Geyer. Bernard Geyer is Zanvil Krieger Professor of Children's Health in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. He trained in pediatrics and preventive medicine and directed the Maternal and Child Health Agency in the Massachusetts Department of Public Health. Dr. Geyer has been active in MCH policy at the national, state, and local levels. He is a member of the Institute of Medicine and chairs the board on children, youth, and families. In the past, he chaired the IOM committees on national immunization policies and practices and on the poison control system. Dr. Geyer chaired the Maryland Commission on Infant Mortality. Dr. Geyer's areas of research include low birth weight and infant mortality, child development and pediatric care, immunization services, childhood injury, and urban health. He was PI of the National Evaluation of the Healthy Steps for Young Children's program. He directed needs assessments for the Massachusetts MCH program and for Baltimore City Healthy Start. He is the author of more than 300 published papers. And with that, I'd like to go ahead and let our first speaker take the stand.
Thanks, Molly, and thank you for inviting me to be here today. What I'd like to do is just give you a little bit of background information on how vital statistics data come to be. Talk a little bit about what's happening in Maryland now with respect to birth certificate data, and also talk about some challenges that are affecting vital statistics data on the national level as well as on the state level. And then after that, I'd like to turn the session over to Dr. Geyer for his commentary. Most of you are probably familiar with the many reports that are generated using national vital statistics data, many by the National Center for Health Statistics and many by other researchers. But you might not be aware that the collection of data is not a federal responsibility. It's a state responsibility. Well, states and other types of jurisdictions. So the recording of the actual events, the birth, death, marriage, divorce, or fetal death, is the responsibility of the jurisdiction where the event occurs. And that includes the 50 states, the 5 U.S. territories, New York City, and Washington, D.C. And depending on the type of data, the data are collected from new parents who are delivering in hospitals, birthing centers, by physicians. Death data is collected from nursing homes, medical examiner office, and state anatomy boards. And the data are reported to local and/or state health departments, where the records are reviewed, edited, processed, and registered. And for death data, causes of death are coded according to international ICD-10 standards. And then data files are prepared and used for a variety of purposes. The 57 jurisdictions and the federal government have a cooperative arrangement to prepare national vital statistics data. The 57 jurisdictions collect and report the data to the federal government with the help of NAFSIS, which is the National Association for Public Health Statistics and Information Systems, which is the member association that represents the states. And the federal government is responsible for compiling the data and preparing a number of analytical reports as well as data files that are used for a variety of purposes. In order for the states to provide consistent data to the federal government, there's a process in place to prepare standard certificates that the jurisdictions who are collecting the data use. And these standard certificates are revised periodically. The last revision was in 2003. The reason that they're revised is so that they can reflect changing needs in terms of legal requirements, administrative requirements, and research needs. The development of the U.S. standard certificates is a collaborative effort involving the states, the National Center for Health Statistics, and other stakeholders, mainly researchers and government agencies. And even though all of the states, or really all of the jurisdictions, are required to collect a standard data set, each state makes some changes to reflect the needs of their jurisdictions. So even though most of us are very familiar with the use of vital statistics data for public health purposes, this really is not the primary reason that the data are collected. Really, the data are collected for civil registration purposes. And the certificates serve as a legal record of the fact of the event, the fact of birth, death, fetal death, marriage, or divorce. And the actual legal documents are used for a variety of purposes, of legal purposes. So even though the original role of vital statistics were for civil registration, very early on, the system started evolving into a public health data system as well. And I don't think I really need to go into the details for this group on how vital statistics data are used, but they're used for a variety of really critical public health purposes. Vital statistics data are really critical public health data sets for a number of reasons. One is that the data items that are collected are revised periodically to take into account current needs. So they evolve to meet critical public health needs. Another reason that they're so important is because there's almost complete reporting, and not because everybody's so diligent about providing data for public health purposes, but because the reporting of the data is mandatory for legal purposes. So, the public health groups get the benefit of the mandatory legal reporting of the information. And until recently, and I'll talk a little bit more about this in a few minutes, there's consistent data among the jurisdictions. So the data that's collected by the states can be used to prepare consistent national data. Recently, the vital statistics system has begun to evolve into a national security system. And there was some movement toward this even before 9/11, but since then, the need has been much more pressing. And actually, the Intelligence Reform and Terrorism Act of 2004 talked quite a bit about new requirements for birth certificates and also for death certificate information. It sets minimum standards for the collection of birth data and also the processing of data and the issuance of legal copies of certificates. It requires certain federal and state agencies to verify the authenticity of the birth certificate. So it won't be enough anymore to just present a copy of your birth certificate. The agency will check to make sure that it's really a valid certificate that's on file in a vital records office. The legislation also requires matching or rapid matching of birth and death certificate data, so that birth certificates are marked deceased quickly and can't be used fraudulently. So, there's an evolution into an area that really no one ever expected would be a use of vital records. Although an update of this is, even though the legislation was passed in 2004 and the regulations were supposed to be available within a year, not much is happening. A large group of us were involved in preparing the background information for the regulations years ago, and we expected to hear something quickly, but there really has been no movement. And without the regulations, there's been no funding appropriated for the states to move forward with what they need to do to be able to meet these standards. So sort of in a holding pattern in some respects, although in other respects, we're trying to move forward to get systems in place so that when the regulations do come out, the states are ready. And NAFSIS has actually developed two huge data systems that will help the states meet the requirements of the legislation. One is called EVE, the Electronic Verification of Vital Events, which will allow federal agencies to determine whether a paper certificate they have in front of them is in fact a legal copy of a certificate that's on file in a vital records office. And then the other system is STEVE, State and Territorial Exchange of Vital Events, which will allow states to share data very quickly across borders so that the birth certificates can be marked deceased quickly, because obviously not everybody dies in the same state where they were born. And in order for STEVE and EVE to be able to work, the states need electronic birth and death systems. And that's something that not all states have at this point. So states are slowly moving in that direction. And I'll talk a little bit more about that, too, in a few minutes. So the electronic birth and death systems are necessary really for civil registration purposes, for public health purposes, for national security purposes, and are really critical for another new role of vital statistics, which is as a public health surveillance system. This is an area where there isn't really enough progress. in my opinion, really vital statistics should be available quickly. Right now, I think the most recent national data that's available is 2006 birth and death data, and it's 2010. You know, what do you do in 2010 with 2006 data? I mean, certainly no surveillance. So, you know, really, the vital statistics data, in order to be a useful public health surveillance tool, needs to be available quickly so that we can monitor trends as the data are collected, allow states and the federal government to identify problems in real time, not 4 years later, and also need to be able to allow for the collection of additional new data items. Right now, U.S. standard certificates are revised every 10 to 15 years. So if a new issue is identified now, it's not really very helpful to say, well, in 10 years when we implement a new certificate, we'll add it. So moving on to what's happening in Maryland now. Maryland is in the middle of a multi-year project to replace all of our vital statistics systems: birth, deaths, fetal deaths, marriages, and divorce. And right now, we just finished our new birth certificate system. It went live in January, and we're actually registering births and issuing certificates, so that's a good thing. Obviously, we're going to have a lot of work to do with the quality of the data. It's a new system for everybody, for the hospitals, and for us, so there is going to be a bit of a learning curve, but we are getting data. We're going to start working on a death system, hopefully in April. We do have funding for that, and the plan is, once the death system is done, to implement new fetal death, marriage, and divorce systems if there's funding available, and we hope that there will be. So just to give you an idea of the systems that we've been dealing with, our birth system has been our best system, and that was a DOS-based system that we've been using since 1993 with really no improvements at all, so you can only imagine. And that was our good system. Our deaths, we collect death data the same way today as we did 100 years ago, which is on a piece of paper. And the way it works is the hospital will fill out part of the certificate, and then the funeral director will fill out another part of the certificate, and then chase the doctor down for a signature. I mean, literally, you know, they hang out, and the funeral directors hang out in outside of ORs, in front of doctors' cars, you know, in front of their houses, in a desperate attempt to get a signature on a death certificate so that the certificate can be registered. It's really pretty crazy. And then if there's an error, you know, we don't allow scratch-outs or whiteouts, so the process starts all over again. So needless to say, we're all really anxious for an electronic system. What we're expecting from the new systems is that obviously data collection will be improved. The process for collecting data will be improved. There are a lot of features built in that will help to prevent the fraudulent use of certificates. We'll be able to comply with the requirements of the Intel reform legislation. And we were able to move to collect the 2003 revised U.S. standard data items. Now, you're probably wondering why we're excited in 2010 about collecting 2003 revised birth certificate data items. But I'll talk about that in a minute, too. So just to tell you a little bit about some of the new data that will be available. On the new revised certificate of live birth, there are modified data items, new data items, and then also some features to help collect better quality data, including standard worksheets, much more detailed instructions than we've had in the past, and specifications for electronic systems, and lots of consistency checks and edit checks. Among the modified birth certificate items are, instead of collecting the number of years of education, we're now collecting information on the highest degree, because the numbers really didn't mean a lot. I mean, you could have 16 years of education and still be in 4th grade. So hopefully by collecting information on degrees, we'll have better quality data. We're also now collecting multiple race information. In the past, we could only collect one race. Now parents are going to be able to choose as many races as they feel apply to them. In the past, with cigarette smoking, we just asked whether the mother smoked, and it really wasn't clear whether the mother smoked the day she delivered or when she was 10 years old. Now we're asking whether the mother smoked 3 months before pregnancy, and then in each of the 3 trimesters. There's also detailed, much more detailed information on method of delivery and fetal presentation, and a different list of congenital anomalies. In terms of new data items, we're now collecting information on fertility therapy, which is really important, especially in Maryland, where there are so many ART resources, and the percentage of ART infants is really high. We believe high enough to be at least partly responsible for the increasing percentage of low birth weight that we're seeing, and definitely the increase in multiple births that we're seeing. So we're really excited to finally have this data. We're also collecting information on BMI, on participation in WIC during pregnancy, source of payment for delivery, infections during pregnancy, which obviously has an impact on outcomes, maternal morbidity, breastfeeding, and in Maryland, this is not the last item, parents' length of time in the United States, is a Maryland-specific item that we're asking parents who were not born in the United States. So we're really looking forward to seeing what impact that information will have on infant outcomes also. So in addition to the revised and the new data items, there are also other improvements in the process. So in the past, hospitals could use any worksheet that they wanted to collect information that went on to the birth certificate, or none at all. And I mean, we know that in some hospitals, a birth clerk who had really very little or no knowledge of medical terminology would fill out the birth certificate. So needless to say, we didn't get great quality data. Now there are 2 standard certificates, or 2 standard worksheets, one for the mother to fill out and one for the facility to fill out. So we're really hopeful that will give us better quality data. There are also detailed guides for the birth clerks who are entering the information into the system, information on where to look for, where in the medical record to look for information that might not be available on the worksheets. And then there are also detailed specifications for electronic systems with consistency checks. So for example, if the gestational age is 40 weeks, it's unlikely that that the birth weight would be 400 grams. So those things will be caught as the data are being entered, so hopefully they can be corrected on the spot. The goals of the new system are, first of all, to provide new and improved data for public health purposes, and also, hopefully, better quality data. So even though this is a big step in the right direction for Maryland, Maryland, and actually most states, are not out of the woods in terms of improving vital records or vital statistics data. As I mentioned before, there was a delay in the adoption of the 2003 certificate revisions. Originally, it's in the late 1990s when the National Center for Health Statistics started talking about doing a certificate revision. They assured the states that there would be funding available to the states to move to the new certificate, and then also additional funding for the new data items that would be on there, because the certificate is substantially longer now than it was before. That never happened. There was never any funding provided to the states, and at the last minute, NCHS told the states to implement the certificate revisions as they could. So 2 states implemented the new certificate in 2003, and a few more states have been coming on ever since, every year since then. And with the new systems, with the new electronic systems, it's not as simple as just printing a new piece of paper and handing it out. It costs millions of dollars to build systems, and states just couldn't do it without any federal support. So that's why the process of adopting the 2003 certificate revisions has been going on for so long. And I mean, there are many states that haven't even started the process yet. And that, of course, means that since 2002, there hasn't been a standard US data set, which is really pretty amazing. So in addition to problems with adopting the new certificates, underfunding on the federal level has also had some other really serious consequences over the years. First of all, there was the elimination of the abortion reporting system, the marriage and divorce statistics program, occupation and industry coding, collection of certain data items on the birth and death certificates, the elimination of the current mortality sample, which provided more up-to-date mortality data, and then also the elimination of natality and mortality follow-back surveys, which allowed the states to improve their data quality. And then also reduce completeness and timeliness of data, because the federal government, or National Center for Health Statistics, couldn't pay the states what they had agreed to in the contract, so things started getting chopped. So, instead of requiring the states to provide data in 60 days, that may have gone back to 70 days. So there's been an erosion over the years. There are also consequences of underfunding on the state level. Resources are scarce, and what do states do? When the states have customers halfway down the street waiting for copies of birth and death certificates, that's what they have to do. That's where the resources have to go, not toward improving the quality of data. And as a result, other functions suffer, mainly ensuring good data quality for the public health information that's collected. So the National Center for Health Statistics over the years has come up with some thoughts on what they were going to do to solve to deal with their funding problem. Among the ideas that have been suggested were reducing the data set, moving from a large data set to a very small data set, especially with respect to the birth data. Really, all that would be collected from the states would be demographic information, almost no public health information. They talked about eliminating annual data sets and collecting perhaps birth data one year and death data the next year. They talked about sampling instead of collecting the universe of data. And obviously, as a consequence of all this, there would be less data and poorer quality data. The other thing that has suffered over the years and is only getting worse is data timeliness. As I mentioned, the most recent federal data available, or national data available, is for 2006. Part of this is a consequence of certain states not being able to get data to the federal government in a timely way. There's also an issue of the federal government not being able to get contracts out to the states in a timely way, and certain states can't provide data until there's a contract in place. So, these are pretty serious issues. There's also a need for states to follow the money. So, for example, if Social Security will pay the states a little extra for getting fact of death information to them quickly so that they can they can make sure that they're not paying benefits to dead people, that's what the states are going to do rather than try to improve cause of death data when there's no funding available for that. I think another threat to the vital statistics data are electronic health records. Perhaps in some cases it'll be an opportunity, but in other cases it's going to be a threat because the states are going to have much less say over how the data are collected and what the data quality are. It's not clear what would happen to the information that's collected from the parents now. So we're all pretty concerned about that. So what's our vision, or the state vision and the NAFSA's vision, or what do we think needs to happen to really save our vital record system? First of all states need re-engineered data collection system, electronic systems that are based on the national model so that all states are collecting the same data sets. And these systems need to be able to immediately transfer data to vital records offices so that data are available quickly. We need to be able to immediately transfer data to other public health department programs. And if there are any local health departments out there, I just wanted to let you know that with our new system, you'll be able to access your data as quickly as we can. This functionality should be available within the next month or so, but you'll be able to download data for events that occur in your county or to residents of your county who are born in other Maryland counties as quickly as we can. So as soon as the event is registered, you'll be able to see it. We need to have timely transfer of data between states because we need the data both for public health purposes so that we have a complete Maryland data set or state data set, and also we need it for national security purposes. There needs to be timely sharing of data with federal partners so that we have data that's timely, not 4 years old. Obviously, if we're collecting data, we need to make sure that it's complete and accurate. We need to be able to link vital statistics data with other data sets. It would make for data sets that are so much richer than just a birth data set or a death data set. We need to figure out how to continue to evolve from a static public health data system to a surveillance system. And we need to be able to use vital records as an effective tool to protect national security. So, in my point of view, vital records are really in trouble yet. And I think that we're at a critical juncture. Do we allow vital records or vital statistics data to continue to erode as it has been over the last decade? Or do we do what we need to move to the next level? I think the vital statistics data is really taken for granted. It's always been there. People think that it always will be there. And I think that at this point, we need federal support, state support, and the renewed interest of all users of vital records to protect what I think is our most important public health data set. Thank you.
Well, I'm delighted to be the commentator on Dr. Harun's presentation about the updates and changes in the Maryland Vital Statistical System and National Vital Statistics. And I thought I would focus on a few key points that really follow directly from her talk. I guess, when you think about it, most of us have been spending our entire careers doing analyses of old data. And it's often made me think if we were running a business, it would be like running a business knowing your accounts 2 years ago. Nobody would ever think about doing that. And yet we make lots of policy decisions using these old data. So this is an exciting opportunity to think about how can the new vital statistical instruments, which will be available in a timely fashion, be used for better policy making. And the points that I want to take off from in Isabel's talk are really first about vital statistics as a surveillance system rather than as a civil registration system. So I think this is a really key concept, and it opens up all these new opportunities for monitoring trends as the data are collected, for identifying problems in real time. And I think this is the moment for some real creative thinking about how we could use these data sets to do a better job. There are also new birth certificate items that we might want to think about using. How could these be used? If one is a local health officer or a city health officer in charge of a program, how can these data be used? And finally, there are some new data for public health that include areas of research that have been done in the past that really open up new opportunities. For example, looking at maternal risk factors, newborn needs for intensive care. These are directly policy relevant, and how can we use them? So here's what I want to do in this commentary today. I want to think about how these new developments in the vital statistics system could be used at the local level for surveillance and policy making. This means thinking about some of the new birth certificate items, about the fact that electronic filing will allow a timeliness that's never been available to us before for looking at these items. The important questions that we have to ask are really what kind of techniques are available to assess these sort of data? This is something entirely new for us. We have to focus on what are the meaningful variables. There's now the opportunity to be completely buried in data. So if we approach it as data mining, we'll never get anywhere with it. And really, it's a matter of having some sort of framework to allow us to think about what are the meaningful variables. And then how do you avoid needless analyses? By this I mean showing relationships that are well demonstrated, that we don't have to show over and over and over again, that really don't add anything to what we can do either in a policy formulation or in practical work. So here's what's kind of been on my mind as I've been thinking about this commentary. So this is the old system. I mean, back in the old days, those of us who started out in public health, we used to put pins on maps. And it was a perfectly good way of doing it, to be honest. This is a slide I just happened to find somewhere on the web, that just shows kind of dots instead of the usual thing, which we now fool ourselves with the idea that by geocoding, we somehow learn something that we didn't know before. Of course, geocoding does tell us something about the density of a particular problem, but just look at this. This is available right now from the Baltimore City Data Collaborative, and it's a geocoded map of infant mortality for the period 2003 to 2005. So here we are making policy with old data, and it just really makes no sense. How do we go beyond that? And of course, the problem that it leads to is this. I love to collect newspaper clippings. So here are two newspaper clippings. These are separate ones. The first one on the left is from 2003. The one on the right is from 2002. So in 2002, I'm sorry, these are the dates of the publication, but the one on the left is the data for 2002 reported in 2003, and it says infant mortality hits record low, and the very next year, the data for 2003, which we were looking, which is when the article was published, the infant mortality numbers were actually going up when we were saying they were at an all-time low. So this makes no sense whatsoever, and we get into these problems, and people want to interview the health officer on TV and so forth. We get into these problems because we've always worked with data that are not timely and not being used appropriately. So what are the elements then of moving toward a model of using vital statistics data in a kind of surveillance paradigm? Here are the things that are on my mind, and I welcome you to add your own. The first is having a statistical tool that will allow us to use these data in a way that informs policy, and I'll show you one that is usable. The second is having a framework that guides the selection of variables, so you come up with useful analyses. The third is to think about focusing on the intermediate variables, because often the problems here is that we have too small numbers. Focusing on infant deaths, in Baltimore there are about 100 infant deaths a year. It's really hard to make policy with 100 as the number. So really focusing on intermediate variables that lead to actions that can be taken by health departments or providers. And the final one is the issue that Isabel mentioned at the end, which is having the political will to develop and maintain a system that's going to be there over a long period of time that can be used and depended on. Another thought on that, just listening to her speak that I want to make, is there's not much of a constituency out there for vital statistics. And I think that's a problem that those of us who've been involved with this system have not paid enough attention to. How do we make vital statistics really relevant to providers so they want the vital statistics? And they want government to support good vital statistics so that they can make decisions based on it. All right, so I'm going to go quickly through a couple of these areas now. The first is talking about tools for analysis. So I'm sure none of you have ever read this paper, but in the late 1990s, Pat Ocampo and I, who were working with the Baltimore City Healthy Start program, started to think about, well, what could we do with data in terms of analyzing trends and trying to decide in a place the size of Baltimore, for example, with about 10,000 live births a year, approximately 100 deaths, how would we know whether infant mortality is going up or down? And one method for doing that is to use some statistics that have been developed for industrial quality assurance. People who manufacture products that have to be specific to some specification and can't get too large or too small, or else they won't fit into whatever machine they're making, have developed statistics for monitoring the output from particular industrial processes on an ongoing, continuous, real-time basis, so that if the product begins to get too big or too small, they can stop the machine, recalibrate, et cetera, and make sure that they're meeting their quality assurance guidelines. And it looks to me like this slide has come out much too light for you to see, but these are the very low birth weight births in Baltimore, and all this slide is intended to show is that they bounce around all over the place. And looking from one year to the next, you can't tell really what's going on. If you start measuring these by month or some smaller time interval, you really can make no sense of these kinds of whatsoever. And when you apply the statistics to it, you find that there are actually very few places where the Q-sum analysis tells you that the change is really significant or meaningful. Significant is not the right word because this isn't a matter of statistical significance, but meaningful. So we did this retrospectively by taking 10 years worth of data and saying if we apply Q-sum to the 10 years of data, where does it show us there's actually some change that's meaningful? And then we did it prospectively by saying, well, if we had been collecting the data, acting as though we were back in time, if we had been collecting the data at this moment in time and had applied these statistics, would it have shown us that the very low birth weight numbers are actually going too high or too low right now? Too high, obviously, is more important. So that's what we did, and this paper is a kind of demonstration of how to use that. But the point that I want to make is that now that these data will be available in real time, it may be that Q-sum is not the best method. It was just one of many of these industrial quality assurance statistical methods. It may be that others are even better for using, and we could do it on real-time data. So that if you're a city health officer or an epidemiologist, and these data are now coming in on a regular basis, how do we know whether they're beginning to go beyond the limits of what we would consider really beginning to have a trend? Okay, so that's the That's the statistical tool part of it. The second is a framework for thinking about what are the important variables. And here, you know, myself and colleagues here at the school, Donna Strapino, Pat Ocampo, and others, have really worked on this kind of framework for thinking about infant mortality over a very long period of time. And I think it's useful in this context. So the framework focuses you on 4 important areas, and these are all measurable, and there are important variables that will be in the new birth certificates. There are variables in the old birth certificates, but they'll be available to us in a timely fashion now, so that's the really important change. But here, really, there are 4 important things to focus on. One is births. Births themselves are important. I'll go back over each one of these, so I just want to give you the framework first. The second is to focus on important outcomes. Now, obviously, deaths are important outcomes, but there are important intermediate outcomes like low birth weight, preterm birth, and so forth that are more common and more measurable. Focus on preventable infant deaths, that is, causes of infant death that are policy relevant. And finally, focus on the survival of small and sick infants, thinking about systems of survival, systems of management. So let me go back through each one of these and tell you a bit more about what I mean. So the first is focusing on births. And here, obviously, if we had timely data on births and you were concerned about fertility overall, especially in high-risk groups, you could begin to monitor that. There are people who are concerned about the availability and accessibility of family planning. That could come out of monitoring trends in this area. We're more and more concerned about birth spacing and the problem of adverse pregnancy outcomes with births that are too close to the previous birth. Again, that'll be more measurable with these timely data. There's a lot of focus in Baltimore in particular on teen pregnancy, so we could measure just births to teenagers and begin to track those. And now there's an increasing concern about late childbearing and women who've had some sort of reproductive technologies and are more likely to produce multiple births and so forth. Again, all of these different birth variables could be measured, and the challenge to policymakers and program people is to focus on which are the most important, which are the ones really worth keeping track of. Okay, the second item is to begin to focus on what are the important outcomes, particularly the intermediate outcomes. And here again, I think it's a matter of making some decisions up front about which are the most relevant, which are the most important of these outcomes. And there's a whole long list of ones that we could be looking at. Many of these co-vary, however. And you know, we don't need to measure them all, but really pick out ones that are of particular importance. I think the new data on maternal illness and maternal chronic illness in particular is going to be tremendously important to try to understand why low birth weight rates have been going up or not going down, and those should be important. We could begin to think about some of the preconception risk factors. Does the new birth certificate provide us some data on that? What about preventable infant deaths? Well, here, I think in Baltimore, again, we've been particularly alerted to the problem of sleep-related deaths, the large number of deaths from SIDS and sudden infant death in infancy that are related to inappropriate sleep positions or sleeping in co-sleeping and sleeping in dangerous situations. Those could be the subject of this kind of review. These sorts of monitoring of trend data could be tremendously important to fetal infant mortality review committees because they're focused on individual case studies, but they may lose track of what are the overall trends and the overall epidemiological patterns, and analyses of these kinds of data with very timely numbers would make a big difference to those kinds of committees. And then finally, the fourth framework is what about the survival of small and sick infants? And that's really a question about, are the perinatal systems for high-risk moms and for high-risk newborns, neonatal intensive care and perinatal maternity, performing the way we expect them to perform? And you know, is this the time to begin looking, for example, with timely data, timely birth data, timely death data, at whether birth weight-specific survivals by hospital provide really useful data for policy analysis? They should provide useful data for neonatal intensive care physicians and hospital directors. So those are my comments on variables. And now just to sort of, I tried to prepare for myself, and I tried to talk to some of my colleagues about, well, what are some of the things on your mind, that we could do if we had these data available? And here are some of the things that people came up with, We've already talked about monitoring trends in certain kinds of births, teens and older moms, looking at mistimed births. I'm not sure we have data in the birth certificates that would tell us whether births are mistimed or not, but that's something that's a challenge for the future, for thinking about ways that future birth certificates could be modified. But we could, for example, look at whether high-risk births are being delivered at exceptionally large numbers in what we would call level 1 hospitals. Women who are at high risk of a serious adverse birth outcome shouldn't be taken care of in a hospital that's not prepared to take care of a high-risk pregnancy, so that the proportion of births in such community hospitals would be a sort of measure that could be used to tell us whether the system is performing, the regionalized perinatal system is performing the way it's intended to perform. We've talked about some of the high-risk birth outcomes. The links to maternal illness, again, are particularly important to me. This set of variables, though, raises the issue of data linkage. So if we now begin to have birth data available in a real-time fashion, would it make more sense out of some of the analyses to programmatic data, like the WIC program? We've had a lot of debate about whether WIC is an effective program in influencing birth outcome. All those data were retrospective studies from, all sorts of different, none of them were ever planned, randomized clinical trials or anything like that. People have been trying to make policy from data that isn't necessarily the right data to use. Could we do something better now that we will have timely data? I've already mentioned the issue around deaths, infant deaths, SUDI deaths, SIDS deaths, and finally, the birth weight specific data that again, previously mentioned. So these are all opportunities. I'm not sure which one of these will prove to be the most useful, and this is a time that we could have experimentation and real creativity in the system itself. So here's my conclusion then, and open up for discussion, I guess. These new vital statistical changes are going to provide really useful tools for policymaking, for public health. The challenge to us is to begin to think about a kind of surveillance model rather than a civil registration model. It means working with data that are not as accurate as the civil registration data were. So we've got to get a somewhat different mindset about how to do that. Focusing in on a framework that provides causal linkages that are important and makes us look at relevant data, not focusing on analyses that have no particular value or have been shown over and over again. That would not be a good use of limited resources. I want to focus on this provider issue because I don't think we've done enough to do feedback to providers. Some of you know that Donna Sturbino and myself and our colleagues at National Center for Health Statistics have been publishing an article on the annual summary of vital statistics in pediatrics, which is intended to go out to pediatricians and influence their thinking about the overall pattern of birth and death and so forth in the U.S. I'm not sure that article, though, has really accomplished its task of building a constituency for good vital statistics. Again, those data are always several years out of date when we provide them to people. Yeah, they get used a lot, they get read a lot, but they're not immediately relevant. And I think having the new electronically available certificates will really open up this possibility of building a constituency for good vital statistics. And then finally, just an appreciation for the hard work that goes into the providing good vital statistics. When I first came to Maryland, I can tell you that we didn't have access to the kind of data that we now have, and that's very meaningful. So thanks. Thank you.
Thank you very much, Dr. Geyer and Dr. Haran. We now have an opportunity for questions from the audience, and I also just want to take a minute to let people know watching online that you can send in emailed questions to our email at maphtc@jhsph.edu. So, Lynn?
Yes, I was wondering, Dr. Ron, if you could say a little bit more about how these data can be used at a local level, because I remember when I used to be, this is Lynn Goldman, when I used to be in the practice of public health, that local health agencies often wanted to be able to do, fairly basic analyses just to be able to communicate to people in their community about the extent of some of these problems, such as low birth weight, preterm birth, in their counties or even in specific subparts of the county when they were trying to get support for, for more prenatal care or other interventions within the county. And so, what really will people be able to do at a local level with these data?
Well, we've been giving annual data files to the local health departments for years now. Any local health department who wants a file can get it from us right away. Birth data, death data, or fetal death data. And many of them do, but not all of them. We also have had a process in place for years now where the local health departments can download reasonably current data. Well, actually very current data. Twice a week they can download a limited number of items from the birth certificate. But now with the new system, they'll have access to all of the data immediately. They'll see it as soon as we see it. So hopefully this will be very useful to them.
So can I ask something about that?
Yeah.
So when they see it, it'll already have all the edit checks and everything that you do, or will it still have to be verified?
They'll get it as soon as we get it, but there's so many edit checks built into the new system that we don't think that that we're going to have to go through the same process that we used to go through in cleaning up the data, which really was pretty extensive. So, obviously until we go back and start doing reviews of medical records to see what the quality of the data on the death certificate, on the birth certificate looks like, we won't know for sure, but there are lots of consistency checks built into the system, so hopefully a lot of the data will be useful immediately. And then at the end of the year, we'll give the local health departments a cleaned up file that includes all of the changes that we've made over the year. Donna.
Yeah, I had a question, and thanks Isabel and Bernie for a great presentation. But I had a question that had to do with the political will, and I guess it sort of combines both of your presentation, because Isabel, you talked about the erosion of the vital statistics system. And in some ways, I agree with you, it's eroded. In some ways, we have the opportunity now, as Bernie suggests, to actually, with the expansion and with this new online system, to actually have more and better data to some extent than we used to have. But part of my concern has been is ever since NCHS was folded into CDC, we've seen a real erosion in the system. And having gone to a meeting a couple years ago with the birth defects group, where they were talking about whether or not we should have a fetal death surveillance system like birth defects surveillance, and being just shocked that they had no clue that we had already that system and that it was far better than their birth defects system. How do we bring the epidemiologists and the folks who are making decisions at CDC and our partners in the states and even in the School of Public Health into this sort of discussion of the importance of vital statistics systems? Because I think it's historically been more the realm of the demographers and folks trained in MCH to really work with these data, and it's really been less sort of the epidemiologists have been involved. So I wondered if either of you had some ideas on how to bring political will there, besides just with providers.
Well, there's actually been some action nationally. There's an organization called Friends of NCHS that's been very active over the last several years in trying to drum up support, financial support for vital records, and I've actually been involved with that group, and we've gone to talk to legislators, and the group has been very effective in getting some additional funding for NCHS. I think in fiscal year 10, NCHS is due for a $14 million increase, which is pretty amazing given that many federal agencies are taking hits right now. But I mean, I think that that there's been quite a bit of interest recently in trying to preserve the system because, I mean, really, it's an embarrassment for the United States to not have a vital statistics system that's moving forward instead of backwards. So that's good news. The president's budget for fiscal year 11 actually has another increase. Now, whether that will still be there at the end is anybody's guess, but just the fact that he put additional funds into the budget is really great news. For fiscal year 10, we're not really sure how much of the increase that NCHS got will go to vital statistics. They have other surveys and competing needs. So, we're hoping that that there will be some additional funding for vital statistics. But in fiscal year 11, there are actually some earmarks to get all of the states onto electronic systems and move things forward. So we're very excited about that.
Maybe it's worth sharing then with Molly this contact, Friends with NCHS,
Sure.
so that people who actually want to be supportive of the efforts can actually get in touch with that group.
Sure. And I have to put a plug in for NAPSIS too, which has been really, really active over the years in trying to call attention to the problem and getting organizations involved. And then I also have to thank the March of Dimes. They've been really, really wonderful in trying to help get some funding for vital statistics.
Any other questions from our live audience? We do have a few. Yeah, go ahead.
Just a couple of small questions.
Okay.
One is related to breastfeeding as a new birth certificate item. What is that item exactly?
It's a very short question of whether the mother was breastfeeding when she left the hospital. Well, it's really when the birth certificate was completed.
Okay.
And then I didn't quite understand why certain ones of these things got eliminated. What was the, like, for example, the abortion reporting system or the date of last birth or last fetal death? Were certain ones eliminated? I just didn't quite understand.
There wasn't enough funding to pay for everything, so National Center for Health Statistics had to make some decisions, and those are the items that were eliminated.
So one just small thing. So you were talking about the electronic health records and opportunity or threat, and you were saying the state will have less say on how the data are collected, and I didn't totally understand why that was, what the issue was exactly.
Well, right now, the states are involved in preparing the U.S. standard certificates and in phrasing the questions and deciding what's going to be on there and how it should be collected and how the question should be asked of the mother on the worksheets. We don't think we're going to have control like that when the data start coming directly from electronic records. And then there's going to be the issue of, well, what do we do when we don't think that the data are accurate? Right now, we can go back to the hospital and say, this doesn't make sense. Can you look it up again? Can you contact the mother? Again, we're not sure whether we're going to be able to do that when it's not our form anymore that's being completed.
Just a minute. We do have a couple questions from our online audience, and this one comes from the state of Texas. What motivated the Maryland-specific item, parents' length of time in the U.S.? How will this added information be used, and do you think it may be adopted more across the nation?
There are actually a couple of other states also adopting that question, Colorado and I believe New York City. We get questions all the time, or requests for data all the time on outcomes among women who were born in the United States versus outside of the United States. And then, of course, the next question is, how long has the mother been here? Was she here, does she really live somewhere else and she was here for 20 minutes and delivered, or has she been living here for a long time? And just the effect that might have on pregnancy outcomes. So that's why we decided to add those questions. But other states are becoming interested also, so hopefully it'll be added to some other state certificates as well.
Okay. And then there was also a question about birth data collected from out-of-hospital births, particularly home births, and how that information would get integrated and what measures would be taken to make sure that it is quickly and easily included.
The local health officer is responsible for making sure that a birth certificate is filed when there's a home birth in a county. And there has to be a process for proving that the birth really occurred. Usually involves a physical examination, and the local health department makes sure that the birth certificate is filled out completely, and then the information is just added into our system.
Okay. And then how do you think consumers will respond to providing the added birth certificate data elements?
Well, the mothers are asked to fill out a questionnaire in the hospital, a worksheet in the hospital that typically is filled out completely. Parents don't seem to mind providing the information. So far, so good. We explain to them how the data will be used and why it's important, and the fact that the confidentiality will be respected. And we've been very lucky so far in not having much trouble at all collecting the information from the parents.
Good.
New moms love to talk about their babies.
They do. And I should also add that the medical information that we collect as part of the birth registration process is not on the legal part of the certificate. There's very little information on the legal part of the certificate. All of the medical information is confidential, not even available to the parents if they ask for a copy.
Okay. And this question comes from Maryland, DHMH. Funding from the state is often based upon statistical or anecdotal community need at the local level, but such information is often up to 5 years old. How much access to local data will staff at DHMH headquarters have to better inform programmatic decision-making?
As soon as we have data available that we can share, we'll be happy to share it. It should be much available much earlier now than it had been in the past, because it's not going to take us as long to edit the data and clean it up. Okay. So we'll be happy to share it.
Okay, great. Dr. Ford?
Yeah, I've been really intrigued by the issue of political will, particularly in relation to the type of surveillance system that you envision. And national security, there is no controversy about that. So to what extent do you think the issue of developing such a surveillance system could be framed as a national security question, as one that is aligned with that?
Well, different information is needed for a national security system than for a public health surveillance system. For a national security system, you need the legal information on the certificate. For the public health surveillance system, you need the medical information. So it's really two different data sets. So we're talking to two different groups of people. So Homeland Security is very interested in our legal information, but really not interested at all in the public health information.
Well, you know, the other relevant point to that question, Jean, is if you think about poison control centers. So the way the poison control system works in this country, there are about 90, 95 poison control centers. They all use a common data collection form. Every time a call goes into a poison control center, the person who answers that call fills out a screen with data about, you know, the exposure and what the substance is, and as much as they can. And that information is actually uploaded to a computer in Washington every 15 minutes, I think. The entire country is uploaded every 15 minutes. So there, you know, and this was all supported by a kind of national security interest, you know, discovering cases of bioterrorism or whatever the concern, chemical terrorism, whatever the concern is. So I think linking it to that seems to have been a really successful strategy.
You know, another issue that that is being discussed now is, do we really need complete national information for the data to be useful? So, you know, if we think that we need data from all of the states before we can put together a national data set or do anything with the data, that's a real issue, because states have problems from time to time, not necessarily the same, sometimes the same states over and over again, but often, you know, something happens in the state and they're way behind getting data together. But do we really need to wait for the last record to be reported before we start putting a data set together? Or, you know, is it good enough to have 80% or 85% or 90% of the data available to at least be able to start looking at it? So it's just a conversation that's going on now on, you know, what can we do with less than complete data that would still be useful?
Go ahead.
You mentioned that the data was consistent among jurisdictions until recently. Do you mean that's because of what individual jurisdictions are going to be adding, or
no, it's
actual inconsistency among the?
In the past, before 2003, all of the states were collecting data using the same standard certificate. And then all of the states were supposed to have moved to the new certificate in 2003, but that didn't happen because there wasn't funding available on the national level to help the states, which had been the original plan. So the National Center for Health Statistics asked states to move to the new certificate, which has a different set of data items than the old certificate, as they could. So right now, in 2010, we're still in the position of some states collecting the old certificate items and some states collecting the new certificate items. So there isn't a consistent data set now that all states are collecting. And there probably won't be for many more years.
We have another online question about the birth data. So if the medical questions aren't on the legal portion of the birth certificate, then are parents required to answer them?
They're not required to answer them, but they're also not asked to answer them for the most part. There's a parents worksheet and there's also a facility worksheet. The parents worksheet includes questions that the parents are able to answer, a lot of demographic information. The facility worksheet includes most of the medical information that should come from the medical record and from the prenatal care records. But the answer to your question is we can't force the parents to provide information to us that they don't want to provide. Fortunately, that hasn't been a problem.
Okay, good.
Collected as part of...
I'm sorry, I can't hear you.
I said on the other side then, are parents aware of what other information facilities are providing to vital statistics, since they don't get that information when they request a copy?
They don't know the exact data items. We do tell them on the worksheet that that medical information is collected for public health purposes, and we tell them that it's considered confidential information and won't be shared and won't appear on the child's certificate. But we try to explain why it's important that we collect this information. And we do have statutory authority to collect the data.
Any other? I think that wraps it up for today. Thank you again to Dr. Haran and Dr. Geyer for a wonderful conversation about the new information available on the U.S. birth certificates.
Thank you.
Thank you.
Thanks.